So either way works. Any questions before we get started? Wonderful. Okay, I have Jerian from the Ridge today, and she is going to introduce Kamala, who I hope I pronounced it correctly. Awesome. So I'll let them take it away.
Okay, hello everyone. I hope you can hear me okay. I'm in a training room. The air conditioning is going in the background, so hopefully there's not too much interference. My name is Jerian Petrie, as Liz said, and I am a business development representative for the Ridge Behavioral Health here in Lexington. I've been here for about 8 years now, and I serve as a liaison for our community partners and agencies. So anybody who may need to seek out services with our facility, I help guide them and give them the information they need that talks about all of our programs. So I've already talked to Liz about sending her some information through email, and she can share that with you. So you can be familiar and have that on hand should you ever need to utilize our services. And also I can drop off some hard copies at the CASA office here in Lexington for you to grab whenever you are there next. I do want to go ahead and introduce our speaker because she will be the main person that will be talking with you today. But of course, if you need me, I can put my contact information in the chat. And so you can go ahead and have that on hand. Kamala Glenn Taylor is our Director of Outpatient Services at the Ridge Behavioral Health. She began her career here at the Ridge in 2018 and transitioned from the Turning Point Hospital, where she served as the Assistant Director of Women's Programs. During her time at the Ridge, she has served as an assessment clinician before she quickly transitioned to the role as the adult chemical dependency therapist within the same year. She's also worked as an adult psychiatric therapist in the outpatient department. And now she is serving as the director of our outpatient services. She is a licensed marriage and family therapist, a certified dialectical behavior therapist, a certified clinical trauma professional, and is trained in eye movement desensitization and reprocessing, or EMDR. Kamala holds a Bachelor of Science in Biological Sciences from Northern Caribbean University, a Bachelor of Science in Criminal Justice from Valdosta State University, a Master of Science in Marriage and Family Therapy from Valdosta State University, and is currently pursuing a PhD in Medical Marriage and Family Therapy from North Central University. So you can imagine she's a wonderful asset for us here at the Ridge, and we appreciate her time of offering trainings when she can squeeze that in. And I think that you guys will very much enjoy her presentation today. So I'm going to turn it over to Kamala. Thank you.
Thank you so much, Jerian, and thank you guys at CASA for really allowing me to just come on and just chat about something with you, which is near and dear to my heart. And I think it's probably going to be near and dear to you guys' hearts as well because of the work that you do. When Jerian read all of that, sounds like a lot when you hear it read back to you. But really and truly, my passion has been for quite some time in this field of just helping people to navigate really difficult circumstances. And I feel really strongly about trauma-informed care because I feel like that kind of knowledge and awareness can really help us to effect lasting change for people. So I appreciate the opportunity to be here with you guys. And can I just say, for you as volunteers doing what you do, I don't think there's words to describe that. So I hope that you guys feel appreciated in your roles and know that, you know, as you're working with these kids, as you're working with the court system, as you're doing the things that you do, that you are definitely making a change. So I am going to share my screen here in just a second. And I hope everybody can see it. If you could just give me a nod, that'll let me know. Perfect. Awesome. So in order for us to kind of chat about trauma-informed care, it's important to know what it's kind of a little bit about trauma. And I'm sure in the work that you have been doing that you have seen this. Maybe not everybody's been able to put words to what this is, but I'm hoping as we go through that we'll have an understanding of trauma. We'll be able to kind of see, you know, the prevalence of it, and I'm sure you'll be able to recognize how evident it is in the work that you do. And then looking at, finally, what does trauma-informed care look like? All right, so let's start with the basic question of what is trauma? And guys, if you hear that ping continue throughout this next 45 minutes to an hour, that's just my email. Can't get it to go away. So hopefully it's not too jarring. But so the question, yes, what is trauma? If you go with your basic definition, a traumatic event is one in which a person experiences, and that can be by witnessing or being confronted with an experience that can look like actual or threatened death. It can look like serious injury, and it can look like a threat to the physical integrity of yourself or on somebody else. So I'm gonna invite you to do something for me right now. In the chat, if you would, or if you want to talk out loud, tell me what you think are some, what do you think are some things that would constitute trauma? What are your thoughts? All right, witness and abuse, thank you, Jennifer. Rape, yes. Domestic violence, absolutely. Extreme weather, yes. When a child sees mother overdose, yes, absolutely, absolutely. War, shootings, witnessing an unexpected death, removal from your home. Tracy, what's that? Buffalo, yes, we recently saw that happen in Buffalo, that experience where many people lost their lives, yes. A lot of yelling in the home. So essentially, there are lots of things that constitute trauma. I'm having a little trouble with my screen here, guys. I apologize. I apologize, guys. I'm gonna stop sharing for a second because I have a little bit of a glitch here. And yes, Charlene, I see that, not being kept safe by your parents, absolutely. Here we go. Okay, so you guys are absolutely right. All of those things are can definitely be traumatic events. And so what we kind of know, and what we can kind of anticipate, whether you've seen this elsewhere, you've experienced it for yourself, that some of the responses that you are going to have to a traumatic event can include things like intense fear, feelings of helplessness, feelings of horror, loss of attachment. And you guys work a lot with kids. And so attachment, helplessness, all of these things, I'm sure you have seen that in response to situations that kids have been through, not being able to trust caregivers and family and people who should have provided the care that was needed and necessary. Trauma also looks like neglect. I remember the first time that was really made clear to me. And one could say that, oh man, well, you should have known something like that neglect could be traumatizing. But in truth and in fact, it never occurred to me just how detrimental the effects of neglect could be. And so when we're talking about neglect as it relates to trauma, we're talking about absence of physical and emotional care, absence of soothing, just the absence of that caring, protecting, comforting experience that one would hope to get in childhood. Trauma also looks like when we're exposed to repeated or severe events, like someone mentioned, child abuse. And all of these things cause really severe and lasting effects. Somebody mentioned domestic violence. Absolutely. So interpersonal violence has a another section to it that really speaks to why this is so traumatic. It's not just the act of the abuse, but it's also the fact that it disrupts our fundamental sense of trust and attachment. Because interpersonal violence, domestic violence, typically occurs in a setting where I expected a different kind of outcome, right? I expected that this person loved and cared for me. I expected that this would be a good life. And so the expectation doesn't lend itself to reality. And we find ourselves in these situations that now not only am I going through the physical effects of this or the emotional effects of this, or interpersonal violence when we're talking about domestic violence can also include sexual elements. And so not only am I going through all of those things, I'm also reeling from the disappointment and loss of what I thought this relationship should have been. And so it really breaks down our sense of trust and attachment, like I said. So now the question becomes for us, how does trauma occur? What's the biology of this? And for those of you who are kind of looking and the wording is kind of small here, Liz, I will provide this PowerPoint to you guys. I have no problem with that. So you can send it out to everybody who would like to get
it. Does seem like your screen is maybe still frozen from when you restarted.
Yeah.
Because our slides haven't changed unless you haven't moved them. So if you might want to stop sharing for just a moment and then there we go. That must have done it. Whatever you just, well, now it's back to just what it was a second ago. Whatever you just clicked a moment ago.
Okay.
Seemed to have maybe fixed it for a second.
I'm going to stop sharing and reshare.
Sounds good. Sorry about that.
No
Technology
problem.
is always very fun sometimes.
You love it until it doesn't love you back for a second.
Exactly.
All right, let's see. All right, let me know what you're seeing on your screen.
We're still seeing that first slide. What is trauma? A traumatic event is one which a person experienced.
Okay.
Now we're seeing it kind of switched view. And it looks like now we are on slide 4.
Mm-hmm.
Yep. And now slide 5.
Okay.
And now slide 6.
All right.
Biology of trauma. Perfect. Thank you.
I'll try not to mess with it too much.
No, you're fine. No worries.
Keep it going. All right. So important to our discussion is we've got to have an understanding of the biology behind trauma, right? And so I want for you to think about this from the perspective of how do I experience stress? Does anybody on this current Zoom call ever experience stress? Anybody? Just me? I see Liz raise the hand. See a couple of people. I saw Nancy chuckle. So we've experienced stress. And so the stress response for us is really an experience that is coordinated through our processes in our brain. And we utilize a lot of our senses to determine what's going on in our environment. So our senses like sight, smell, sound, touch. And what the brain does with this information that we're getting from our senses, from all of these external areas, is that it's processing the stimuli from our environment based on things like memory. Okay, where have I experienced this before? Logic, does this make sense? And future prediction, will this happen again? So that's what's really happening as we're starting to respond to a stressor. The interesting thing about responding to a stressor now is that we have a section of our brain that's called our limbic system. If you want to think about it from the perspective of the caveman, and evolving all the way up to us. So very instinctual based, right? If you want to think about it even from an animal perspective, very instinctual based. Here's a threat, I respond to the threat. I don't really put a lot of thought into it. So interestingly enough, in this stress process, in this stress response process, the limbic brain is really what is doing a lot of the work here. And what it does, it puts a lot of emotional weight to this stressor. So from a chemical perspective, a big part of the limbic system is something that's called the hypothalamus. And it responds to stressors by doing a couple of things. One, it releases something called adrenaline. Everybody familiar with adrenaline, right? That adrenaline rush that we get when we need to respond to something. That adrenaline rush stimulates our central nervous system. It tells the system that it needs to release what you call norepinephrine, which is another hormone. And what that hormone does is that it locks in on the memory of stress as it's at its highest level. So I want you to think about something that stressed you out in your own life, right? When you think back to that experience, sometimes what you think about is what was most stressful about it, right? You don't remember all the peripheral things, all the little things that might have been going around. You notice the thing that stressed you the most. And that's because the brain does that. And it comes kind of from a protective stance. I need to remember this stressor so I know how to avoid it in the future, right? So memory, logic, future protection. So as norepinephrine is locking in that memory of stress at the highest level, they're also doing this really nifty thing where they're shifting the response away from our thinking brain to our limbic brain. Why is that important? If you think about your own experiences, if you're highly stressed out, depressed, anxious, any of these things, we typically don't make the best decisions then, right? Or do I have anybody in here who's like, oh no, I always make great decisions no matter what's going on? No? Okay. So most of us, that happens because of just the way our brains have developed to deal with things. If there's a stressor, if there's danger, the way that my mind works, the way that my brain works is that, oh, I need to shift all of the attention away from unnecessary processes. So if I encounter a rabid animal, the first thing is not going to be, okay, well, let me strategize how I'm going to deal with the situation. No, my first response is to get out of there. And so that's the way it works in our brains for us to be able to respond to stressors, if that makes sense. So what that means is that our fight or flight system gets activated. And we've all heard about this fight or flight system, right? A lot of us have experienced this in our own lives where we've been in a situation and we've either had to respond, we've had to respond immediately, whether that was by fighting, whether that was by running away, whether that was by freezing. A lot of us experience different kind of responses, but this is a limbic brain response. And so we stay aroused, activated until the stressor is removed. I used to like to tell clients this story. It's a made up story, guys, didn't really happen. But let's say we all decided here in this group that, you know, maybe we weren't meeting on Zoom, maybe we were doing this in person. We were like, you know what, let's take a walk. Let's make this interesting. We're gonna go up and take a hike somewhere, right? And we're all having fun, having a great time. Everybody's laughing and gabbing and we're all good. Until we get to a certain part of our journey and we encounter a wild animal. A lot of us are gonna have different kind of responses in that moment. Some of us are gonna try to figure out how we're gonna fight our way out of this. Some of us are gonna run away. Some of us are gonna stay frozen. We're gonna have all kinds of responses to this. But I wonder if you notice, no matter what your response is, once you've backed out of that situation, there's almost like a energy drop, right? I escaped that experience, right? And so that's what we're talking about. When we're in those moments of stress, when we're experiencing the stressor, that arousal, that being on edge, that fight or flight stays aroused until we get out of the situation. Interestingly enough, when we're in that arousal state, we're not really focused on memory, concentration, we're not doing math in this situation, guys. All of those processes are really decreased because the goal right now is to survive. Now, when it comes to the discussion of trauma, now we've been talking about just a regular stress response, right? When it comes to trauma, think about what that might mean if I'm in a situation where I'm repeatedly exposed to stress, right? My body is always in what we call hyperarousal, always activated. And so now I have a situation where, because I'm always hyperaroused, because I'm in a constant state of stress, and be it from I'm in an abusive relationship, to I'm being abused by a parent, to I have lived through a horrific accident and I am reliving that experience in my memory. No matter what, imagine being in that state of hyperarousal. There might be times when some other stressor comes our way where how we respond to it seems really disproportionate to the stressor, right? But it's because I'm living in a state of being on edge, if that makes sense. So now, when you think about what that means, I want to add the element of neglect. Now, in the work that you do, many of you work with kids who have been neglected in one way, shape, or form. And even though we think about neglect as a more subtle form of trauma, when you start to combine that neglect with abuse, and we start to recognize that this is an ongoing experience that this person is going through, what we start to realize is that that hyperarousal, that being on edge, also kind of comes together with being really hypervigilant. I'm always waiting for the shoe to drop. I never trust you. So you have this experience of working with kids where, gosh, this kid always seems to not respond really well to things, always is combative or argumentative, or is always withdrawn and quiet. We see all of these different kind of responses. And what's really happening is that because this traumatic experience is so pervasive, they're living in a state of survival. And it's not even survival in the sense of, I've got to think about how to get my next meal. It's survival in the sense of, I'm always scanning my environment for threat. All the time, every single day. Can you imagine how hard that has to be? And to sometimes not be able to put words to that, or not have anybody in your experience who takes the time to realize that that's what's happening for you. Significantly traumatic. So let's talk a little bit about how often we're seeing this. You guys could probably give me some statistics yourself if you came together and said, hey, this is how often I see this kind of stuff when I'm working with these kids. But in a couple of studies, what they saw was that 90% of public mental health clients have been exposed to trauma episodes. 82% in a study in Massachusetts of all adolescents and children in continuing care were reported with histories of trauma. I'm almost certain that you guys would agree with these numbers. Do you feel like you see it a lot? Yeah, I'm sure you do. So now, let's talk about impact. We know that we see it. We know that it's a response. It's a natural response to stress. But let's see how this is affecting our kids, our adults, the people in our lives. We talked about fight, flight, freeze. There's another response to repeated trauma, repeated stress that's not often talked about. I've listed it here as submit. You might see it in another context referred to as fawn. So let's break it down a little bit. We know what fight looks like, right? These are our kiddos and adults that tend to be argumentative, aggressive, abrasive. You know, every time there's an interaction, it feels like I'm going into battle. Flight, we know what that looks like. These are the people that are running away. These are the people that we can't get to sit still, to do anything, to focus. We know what our freeze looks like. These are the ones that we notice that are really shut down. They don't engage. It feels like no matter what I do, nothing's getting in. And then we have our submit, our fawn. These are the people who their response to trauma has become, I'm gonna try to get along as best as I can. These are the lack of boundaries. These are the people pleasers. I'm gonna do whatever you need me to do. The challenge with that is that, and sometimes I think this category gets overlooked, because when we've got kiddos who are people pleasers, because that's what they've learned to do, that can look like somebody who's really very compliant, right? In a positive context, that works really well. But what happens in the negative context? It's the same need to please. What it is really just a way to try to cope with the situation that I'm in. Again, in all of these, you're gonna notice, no matter if I've got a fighter, a flighter, a freezer, or a submitter, you're gonna notice that their focus is on survival. All other non-essential tasks are gonna get shut down. You'll notice things like, why is this person not thinking through situations? Why is it that they just always seem to be just reactive and responsive? But that's because of what we talked about before. When we're in survival mode, when we're in that stress response mode, our brains essentially shut down our rational thinking. It's not accessible to us. And so we find ourselves really just acting instinctually. If you've got a kid, an adult, anybody who's been exposed to trauma, and we're talking about the repetitive type now, you might notice that this is somebody who, I'm calling it their alarm system, but this is where the hyperarousal comes in. This is where constantly being on edge comes in. That's where that alarm system, that system that says, hey, something dangerous is going on, you need to pay attention, that doesn't get turned off because I'm constantly in a state of danger, whether it's real or whether I've moved away from that situation, but emotionally and mentally, I still feel like I'm there. And so it can cause that natural alarm system to no longer function. That's why I'm always on edge. That's why I'm always hypervigilant. That's why when stuff comes up, I respond to it in a way that seems really disproportionate to the situation. We can see a lot of emotional and physical responses. You can see a lot of numbing. We can see a lot of avoidance. Trauma also impacts, like we talked about a little bit earlier, just the individual's entire sense of safety, and can really diminish the capacity to trust others. So when you encounter kids that, you know, they don't ever believe what you say, it may be that that's what they've learned over time. It's not so much, it's not about you. It's really about, this is what I've done to protect myself all this time. And so having the ability to have compassion and empathy and patience as you're working with somebody who's been through through lots of trauma is essential. You might notice other things like this. We're talking about hyperarousal. You might see a lot of nervousness, with kids that you're working with. You might see a lot of jumpiness. You might see that they're really quick to startle. You might hear stories about, I keep seeing these images of these bad things that happened to me in my head, or I keep feeling like these bad things are still happening to me. You may hear experiences of dreams and memories that are just constantly, you know, a part of this person's experience. Or you might experience seeing someone who's, you know, they're really numb most of the time, or they seem really shut down, or they seem really disengaged. You might see them pulling away from relationships, pulling away from activities that you're trying to get them involved in. And you might hear them talking about avoiding things because it makes me remember. And so when we're talking about impact, these are the things that we have to anticipate. So now that brings us to trauma-informed care. What does this mean now that we know the things that we know? When you're working from a trauma-informed care perspective, one of your first aims is going to be to avoid re-victimizing people. And we can do this in little ways that we're not even aware that we're doing them. So I always tell this story, also because I have permission to share the story. I still won't give like, you know, details, you know, names and those kinds of things. But I remember at one time years ago working with an individual who had experienced sexual abuse, physical abuse, emotional abuse at the hands of a family member. And I remember the first time I encountered this person, and at the time I was in a different facility, and this was residential care. And there was a story about this particular patient. And the story was that she never completed. She was always combative with staff. Or she was that person that when you saw her on the roster coming in, you were like, oh boy, that was the story. And so, interestingly enough, she got admitted, got into my care, and I noticed, looking back at the past admissions and talking to people who had worked with her before, that there was a particular trigger that always seemed to come up. And once that came up, she was out of there. The trigger was when people called her by her full name. And that might seem like a strange thing. Why would that impact somebody? Why would that be a trigger? And so in working with her, what I discovered was that her abuser would always call her by her full name right before the abuse was getting ready to occur. And so the association in her mind between her name was that she was going to get hurt. And it seems like a small thing, but she had never had the opportunity to work through what had happened to her. She had always hit this point where her full name would be used, she'd get combative, and then that would be the end of treatment for her. And so we worked with her and said, okay, well, how would you prefer to be referred to? And we'll work with that. And we did. And for the first time, it allowed her to work through the trauma that had occurred to her so many times. Accept it, which sounds like a hard word, but accepting doesn't mean that it was right, but accept that it had happened, but she didn't have to live in that place anymore in her mind. And so once we were able to work with her that way, she eventually came to a point where it was okay for us to use her full name, because she no longer had that emotional and mental association between her name and the trauma that she'd experienced. And so one of the first aims of trauma-informed care is to avoid re-victimization. And a lot of times that can look like just being compassionate and respectful and asking questions about what people's preferences are, giving them a sense of empowerment. Trauma-informed care also looks like being able to appreciate problem behaviors as ways that people learned how to cope. One of the big ones is always, this person is manipulative, right? What if manipulation was the only way this person was able to survive before you came along? That means that's all they know. That means they've not had the opportunity to learn something different. They've never had the opportunity to be able to trust that somebody is actually going to be there for them, is actually going to follow through. And so they've learned early on that the only way I get what I need is if I get one over on you. And so recognizing, okay, I see you manipulation, but you're probably here for a reason. Let's figure out why. Let's figure out how I can create a relationship with you where you don't feel the need to use that because it's the only thing you know, and let me teach you another way. Trauma-informed care also looks like maximizing choices. One of the big things that trauma takes away from people is a sense of power, a sense of control, a sense of ownership over their life. My life doesn't belong to me, it belongs to somebody else. And so being able to give even small choices. The choice that we gave the client that we had was the ability to say, I prefer not to be called this. Call me this. To us, it may not seem like a big deal, but it gave her a sense of ownership over her experience and gave her a sense of control over her healing process. Trauma-informed care also has to be culturally competent. That means that I don't know everything about you, you don't know everything about me. Let's learn together. What's natural and normal in my context may not be the same in your context, because we all come from different backgrounds, right? Different family experiences, different, culture in terms of, ethnicity. We have all kinds of different experiences that shape who we are and how we understand the world. So I always encourage people, if you want to be trauma informed, one of the first things you have to do is learn how to ask a lot of questions and recognize that, take a step back, I don't know everything. There's this author that I once read that talked about this in a way that I thought was really beautiful. And the statement that I remember it being said was, the map is not the territory. And if you can get what that means, it's that looking at a map is never the same as being in the place. And when we think about cultural competence, when we think about learning from somebody else, that's really it. I can know something about you, but I can never experience your experience. And so being able to ask questions and be open to understanding somebody else's experience is extremely important. And this kind of ties into understanding survivors in the context of their life experiences and their cultural background. That's what we're talking about. Trauma-informed care is about treating people who have special needs due to trauma in a sensitive and respectful way. I can't emphasize this enough. I have seen very little things that have really impacted people in great ways. It's being able to recognize that certain things that we do in our caring process can be unintentionally triggering. So if you notice a response or reaction to something that you've done, said, or a way that you've approached something, ask questions about this. How could I do this better? What was problematic about how I approached this the first time? It's okay. We don't know all the ins and outs of the people that we work with, but we can learn. We also want to emphasize safety. We also want to create interactions that minimize triggering events. So that requires us to know, to get to know. And I know that's what you guys do as a part of your volunteer work. You get to know people, you get to know their situation, you get to know their environment. So that's wonderful. So you want to emphasize safety, and you want to recognize and create scenarios and environments that are less triggering. And you want to give a sense of control to the people that you're working with. And it doesn't have to look like big things. It can look like really small things. when we're talking about safety and stabilization for trauma-informed care, it's attention to basic needs. You guys already do this. It's connecting people to resources. It's being able to talk to them about self-care. It's being able to identify who's in your support system that's actually supportive of you. And then it looks like also, gosh, how can I help this person to regulate their emotions a little bit better? How can I help them to learn how to self-soothe in ways that are healthy for them? And then safety and stabilization is also about what you're doing today. It's getting educated on trauma and what that process looks like, so that when we approach situations and people, we're coming at it from a more informed lens. As you're working with people, depending on the context where you are, some of the things that I always like to share as we're thinking about trauma-informed care, if you're bringing somebody into an office to talk to them, or if you're helping them to recreate or create a difference in the environment that they are in, then here are just some basic things that you can share. Is your environment calming, or is it really jarring? I was doing a training last week, and one of the things I was talking about is, if I know that I'm really triggered by loud noises and a lot of chaos, Texas Roadhouse is not where I'm going for lunch, man, because I've got the TVs going, I got music playing, I got people talking, like it's too much, way too much, right? And so just being able to recognize, okay, does my environment promote calming? What's the lighting like in this place? Is there music here? Is there space for, different things? Is it attractive? Is it comfortable? Those are the kind of questions to ask ourselves about how can I make an environment more calming and stabilizing for somebody who's experienced trauma. And whether you're going to a home or you're bringing somebody into an office, these are things that you can talk about and say, hey, how can you make the environment that you're in a little bit more comfortable and a little less, and make it feel a little bit more safe for you? And sometimes it's little things like this. There's also things that you can do, just basic activities that are really kind of just helpful and calming. For a lot of the people that I've worked with, you'd be surprised to know that some of the kids that I've worked with that have even had experiences of self-harming, like that was something that was their go-to as a way to cope. But one of the things that we tried out was fireball candies. Why did that work? It was jolting, which in the way that their self-harming was, but at the same time, it wasn't harmful to them. Now, is that the end all be all? No. You do want to connect people with resources and therapy and, to work through when you're seeing those kind of behaviors. But these are just some the activities and things that we can do to ground in the moment. Aerobic exercises. Some kiddos really benefit from things like weighted blankets, something that creates just a little sense of safety and security. You can encourage self-soothing activities like yoga, meditation, visualization, deep breathing, art therapy. There's all kinds of resources out there to connect people with things that can help. Does it take away the experiences that they've had? No, but it does help them to regulate and become better at self-soothing. Maybe some of the people that you encounter can't change everything in their environment, but maybe they can have a couple of things that are just for them that help them to self-regulate. Maybe that looks like stress balls. Maybe that looks like just motion objects. Maybe, back in the day, lava lamps, those were a thing. Maybe it looks like aromatherapy. But you don't have to limit yourself in terms of things that you can suggest for, creating a calming environment that's helpful for people. Now, lastly, This is one of the areas that I think is, all of it's important, guys. But as you work with people who have experienced trauma, are experiencing trauma, are working through past experiences of trauma, no matter what the case might be, as you do this work, you also have to take care of yourself. I always thought like the analogy of pouring from a cup, right? If I keep pouring, but I don't pour anything into the cup, eventually what's in there is going to run out. And so I imagine that you all do this because you care. I imagine it comes from a place of great passion and great compassion. But we have to remind ourselves that as we care, that we also have to care for ourselves. I also think about this from the perspective of, if you ever travel, if you've taken a plane somewhere, the flight attendants always come through at the very beginning. They give you the safety spiel, right? And they say, if we're in distress and the airbags are deployed and you're sitting next to a child, who do you put the airbag on first? The child or yourself? Yourself. And why is that? Because if I spend all the time fumbling and fiddling and trying to put the mask on the child first, and I pass out before I get done, then I've not really helped anybody. And so self-care for us, self-care as you do this work, is akin to that. It's recognizing that I do need to put that oxygen mask on me first, not because I'm selfish, not because I don't care, but because I can get a lot more done if I take care of me too. And so I encourage people, make sure you're sleeping, make sure you're getting your full rest. If I'm being honest, that's one I'm still working on. I read an article about revenge sleep procrastination, which is where you work and work and work. So you're like, I must do something instead of going to sleep. So that's what I do. So I'm working on it. So we all have our stuff. But make sure you're sleeping, make sure you're eating well, make sure you're taking time to move your body, whatever that looks like for you. Exercise is not always everybody going to the gym and pumping weights. Do what's good for your body. Make sure you are practicing good boundaries. That's a hard one. When you care a lot, it can be hard for you because you don't want to say no, you don't want to disappoint, but practicing good boundaries is essential to taking care of yourself so that you can take care of others. And then making sure that you're always using positive coping mechanisms and not negative ones. Because again, taking care of you is the only way you can keep doing this work. So I hope that this has been helpful, useful. You've learned something new. Feel free to ask me questions. I am going to stop sharing screen for now. And then if there are questions in the chat, or if you want to just unmute and ask questions, have at it. Thank you, Tracy. I appreciate that.
And if anyone has questions, feel free to put them in the chat, like she said, or ask them out loud. But if you have questions, if you walk away, sometimes I know I'll walk away for an hour and then be like, oh, I wish I'd asked that. So if that happens, let me know. Feel free to email them to me and I might be able to kind of coordinate getting an answer back at some point. Awesome. If we don't have any other questions, and I'll give it a couple more minutes as I kind of finish up, but just so everyone on this training knows, from a CASA perspective, you'll get an email today that will be your proof that you've attended this training, and you will be automatically counted if you're a CASA advocate with CASA of Lexington, that'll automatically count into your CEU time. There will also be a certificate, not a certificate, a link to our feedback form, not a certificate, I'm sorry. And if we ask that you give us feedback, because we always like to know what you found really helpful, and if you have further information or further things you'd like to learn about. I'm going to pause real fast. Julie Butcher had a question. She said, thank you. How do we get our kids' referral to you?
So referral process is very easy, but I think Jerry Ann, do you want to take that one?
I can certainly, and I can also, I have a short PowerPoint. It's probably about 8 slides that talks specifically about how to refer to the Ridge and the things that are needed to make a referral. But we have staff that's available 24 hours a day, and we take walk-ins, so somebody can call us, they can walk in, and we do assessments at all times. We can even sometimes do a phone assessment or a Zoom assessment, depending on the nature of the situation. If we can get all the information that we need in that manner, then we can do a phone or Zoom assessment. But I will put the phone numbers in the chat box. And then, like I said, I can also email that PowerPoint to Liz that walks you through the programs that are available and how to refer. So we do inpatient treatment, of course, for acute needs, but we also do outpatient treatment. And so we really do offer the full continuum of care and try to help folks, you know, if they are having a crisis and they come in as inpatient, then we do offer that programming to help them step down and continue their treatment. And that's the program that Kamala oversees, is our outpatient services. So I will be happy to, and yes, as Liz said, if you have questions that come up after the fact, she has our contact information, and we are more than happy to answer those questions later on.
Thank you. And Julie's question actually spurred a question that I had, which is a lot of times we're working with children who are school aged. Are there any sort of programs that partner with schooling so they can do schooling, like an outpatient program where they come and do schooling at the Ridge, or how does that kind of tend to work? Is there programs that you guys provide like that?
So Kamala can talk on this a little bit more, because we do have some programs that are actually based in Fayette County schools. But the other addendum to that, we have full-time staff that are teachers on our facility that work with these students, that work with the kids in their school programs. So if they are with us as a patient, then they are also receiving some one-on-one time with these teachers as well, to help get them up to par with their curriculum so they don't get behind if they are participating in one of our programs. And then Kamala, you can add more about the school-based if you'd like.
Jerry Ann is absolutely right. So there are a couple of things that we offer for child psych, which is our 5 to 11-year-olds. Our on-campus group does also offer the educational component, of course, during the school year, as well as our adolescent group that's on campus. Now, our school programs are really unique in that we have got a couple of adolescent programs that are in school locations. So we've got a PHP, partial hospitalization program, that's run out of the STEAM Academy. That's for Fayette County residents. We've got a program in Franklin County. We've got two programs in Scott County, and we have a program at Paris Independent Middle. So once you've got a kid who's in any of those areas, we've got a lot of different opportunities that we can offer. So for school programs, of course, those are for the school year. So once we're in the summer months, then we encourage you to utilize our campus programs during that time. But yes, we have all of the different options that you could explore for any kids in need.
Awesome. And Brittany Thomas, I just saw your question in the chat. Does that answer that question for you? About the IOP program that allows kids?
Yes, yes,
Okay.
it does. Thank you.
Perfect. We had the same thought. And then Jean asked, if we have a CASA child who is inpatient at the Ridge, do you have suggestions or guidelines for how to decide whether and at what point for us to visit in person?
Jerry Ann, correct me if I'm wrong, but we are still not doing visitation at this time, or have we changed?
No, that is correct. We are still limiting in-person visitation due to COVID, and we are encouraging Zoom and phone calls for our patients, so they are allowed to communicate during certain times of the day with their family. But yeah, I was going to ask you, Kamala, as far as any other type of contact with their CASA volunteer, how if you have a recommendation on that or how that works, or if we need to ask anybody from the inpatient side.
Well, what I would encourage people to do in general is that if you've got a child who is in our facility, whether it's inpatient or outpatient, as long as, guardian or whoever the guardian is involved, if they would like to add you to a release of information, that typically allows us to be able to communicate with you. And so you just want to encourage your parents and guardians to do that.
And you might not be able to answer this question, but I know all of our CASA advocates also have a court order that allows for release of information right on there. So I'm assuming they could also submit that as well.
Yeah.
Okay, perfect. Wonderful. Great questions. Anyone else? Any other questions popping in the last couple of minutes? No? Okay, so we really appreciate both your all's time. I feel like I learned a lot. It was really, really informative. And like I said, for everyone on here, if you're a CASA volunteer, you'll get that email with a feedback form. Please provide us feedback. And then also at some point, I will be sending out the PowerPoints and extra resources as well. If you have any questions, feel free to reach out to me and I can get them to our two lovely presenters and get that information hopefully answered for you. Thank you guys so much for hopping on today. We're right at an hour. And I hope you guys have a great rest of your Tuesday. If you have any questions or concerns to follow up on, please feel free to email me. Thank you so much, ladies. We really appreciate it.